and welcome to today's webinar, Caring for Your Feet with Pustular Psoriasis. My name is Bev Bromfield, and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer's audio system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane, and the dial-in information will be displayed. In addition to pre-submitted questions, you'll have the opportunity to submit questions today by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, dermatologist Dr. Jeffrey Crowley. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, Amgen, Janssen Pharmaceutical Companies of Johnson & Johnson, and UCB for their support of today's webinar. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the lives of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan in July 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over 5 years, NPF will focus on achieving 3 goals: lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPF's mission-related goals. By viewing today's program, you've taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes NPF has funded close to $30 million in grants and fellowships. This includes almost $3 million in grant fellowship funding announced last July. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged a definition of prevention to better guide proposal development, and that's how it expanded to include disease relapse and comorbidities. Now in phase 2 of the funding cycle, NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. Now in its 3rd year of funding, this grant funds projects that will significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Corrivitas National Psoriasis Patient Registry, formerly known as Corona, is the largest independent observational registry of psoriasis patients in the United States. This registry collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 12,700 patients enrolled at more than 521 sites across the country. Your dermatologist may be enrolled as an NPF Corrivitas National Psoriasis Patient Registry site. If you're not sure, ask. If they're not, encourage them to join. Citizen Scientist is a platform where you as a patient answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment for psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or guttate psoriasis, and be a candidate for office or home phototherapy. There is no washout of topical, oral, or biologic medications, and the study is designed to be easily incorporated into routine patient care. It is also unique because it includes equal representation of all skin phototypes. The NPF Annual Survey is a data collection effort the Foundation has conducted for 2 decades. This important research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you are contacted about this annual survey, we'd appreciate you sharing your experiences with us. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in virtual or live team NPF events such as Stamp Out Psoriasis, Walk, or Cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about signs and symptoms of pustular psoriasis on the feet, current and upcoming treatment options, as well as management strategies to help care for your feet with pustular psoriasis. What you can do to overcome the physical, emotional, and social impact associated with pustular psoriasis, resources to help learn more about psoriasis, psoriatic arthritis, and related health conditions. Now I'd like to introduce you to our speaker, dermatologist Dr. Jeffrey Crowley. Dr. Crowley is a board-certified dermatologist with Bakersfield Dermatology and Skin Cancer Medical Group in Bakersfield, California. His clinical interests include a focus on psoriasis, managing skin cancer, and melanoma. Additionally, he has served as a clinical faculty member at both Stanford and UCLA. Dr. Crowley has been a principal investigator for over 100 clinical trials and is a member of the NPF Corrivitas National Psoriasis Patient Registry. Dr. Crowley is a President's Council member of the National Psoriasis Foundation, which represents an elite group of healthcare providers who are committed to the mission and activities of the Foundation. He is also a past member of the Medical Board of the National Psoriasis Foundation and a member of the American Academy of Dermatology, CalDerm, American Society of Mohs Surgery, and the American Society of Dermatological Surgeons. It's my pleasure to welcome Dr. Jeffrey Crowley, who will present today's webinar, Taking Care of Your Feet with Pustular Psoriasis. Please welcome Dr. Crowley.
Thank you, Bev. It's my pleasure to be here, and I certainly echo everything you've said about the importance of the National Psoriasis Foundation. The ability to take on some of these tasks that no one else is going to do, such as some of the patient initiatives, is really been critical to our patients and to our ability to find new treatments for our patients. These are my disclosures. I work with a lot of pharmaceutical companies, and it's important to work with these companies to provide new therapies. And I've been involved in everything from the Enbrel psoriasis all the way up through the current things that are available now, including some of the oral agents that are coming forward. So pustular psoriasis, this is a world of grays and not blacks and whites in terms of what kind of psoriasis is actually going on, because there really is a spectrum of disease, but there is this condition of pustular psoriasis of the palms and soles that sometimes can occur with very little or no other psoriasis. And that's kind of what our focus is going to be on today. But I also want to talk about general plaque psoriasis of the feet and some of the things that you can use to improve that. Is it plaque psoriasis? Is it pustular psoriasis? Is it both? We're going to show lots of photos today, but pustular psoriasis means that you have little white pus-filled pockets. And sometimes there are round areas of psoriasis. Sometimes the whole thing is just pus-filled little pockets. And one of the hallmarks of this is the pain that you can have with pustular psoriasis. Now, there can be a form of generalized pustular psoriasis, and this can involve the entire body. This can be acute onset. It can make a patient very ill. These patients often do need hospitalization because it can be so extensive. Yeah, it's a systemic disease. You have fever and swelling and malaise and joint pain, and fatigue, headaches, increased white blood cell count. And this is a very different condition. There are some treatments that are being studied for this. There's IL-36 antagonists that are showing some promise, and we'll probably see some things approved in the next year or so for generalized pustular psoriasis. There's a condition called Acrodermatitis continua of Hallopeau, where you actually get a lot of nail involvement. You can see the psoriasis surrounding these nails, nail destruction. You can even get some bony resorption. So this is a subset often associated with psoriatic arthritis. In fact, I really think it is a form of psoriatic arthritis. And this is a fairly rare condition. I've only seen a couple of patients in my whole career with this condition. Palmoplantar pustulosis, a little bit more common than the ACH is. And as you can see, pustules of the palms, pustules of the feet. The key thing here is pain. There's a lot of pain involved with this condition. And if you suffer from this, you know how it can be so painful to walk and to mobilize and to do any kind of activities because of the level of pain here. But also you can have itching, bleeding, scaling, redness, blistering, nail loss, and joint pain, and psoriatic arthritis can also be present with this condition as well. It's fairly rare, okay? The incidence is about 0.05%. There are some areas where it's more common. It's more common in Japan and other areas in Asia. There are some genetic predispositions that can lead to the development of palmoplantar pustulosis, but it is quite a vexing condition and a condition to what our current treatments really don't manage well, and we'll go into that. Again, the symptoms: pustular psoriasis, pain. I mean, those are the things that just really wreck my patients' lives when this condition is active, is the pain. So you can have different forms of palmoplantar psoriasis. This was a retrospective review of 150 patients. This kind of goes into that gray zone. So we have some patients who purely have just plaque psoriasis, purely pustular psoriasis. There's a mixed type, and then there's with or without psoriasis elsewhere. So again, this can occur with the palms and soles independently. Sometimes it's just on the palms, sometimes it's just on the soles, sometimes it's both. So it can be all of these things, and every patient is kind of unique in terms of how they present with this condition. Here are some purely hyperkeratotic. You can see the thick scale, cracks, fissures. It's going to be hard to use the hands and feet here. Purely pustular, you can see the studded pustules. Some of them have opened up, and you can see some hemorrhage that can occur. Again, more pustules on the palms. And here we have some hyperkeratosis and some pustules, so it's kind of a combination of both plaque psoriasis and some pustular psoriasis. And again, here again is hyperkeratotic, thick fissures, but there's also studded with some pustules around the edge. So it's not cut and dry all the time. Sometimes you can have a pustular component to plaque psoriasis. Sometimes it is just pure pustular psoriasis. And this is mixed with hyperkeratotic and pustules. And then this is the Acropustulosis of Hallopeau, the ACH, where you can just get incredible amounts of nail destruction. And some of that nail destruction can be permanent if it's not treated adequately. So just overall caring for your feet. I think this is really important. You need to have proper shoes that are comfortable, that are not putting pressure where it shouldn't be. Inserts can be very helpful for this. Trimming the nails is really important so they're not cutting and fissuring into the paronychia, the area around the nail. Moisturizers are important. A lot of people don't want to put stuff on their feet, but moisturizers can be very, very helpful. They're not all the same. If you have those thick plaques and scale on the feet, you're going to need something that's actually going to remove some of that plaque and scale. So regular moisturizers with ceramides are great. So things like CeraVe, Cetaphil, those kind of things can be quite nice. But really, to get some of that dead skin and scale off, you need to use an acid such as lactic acid, glycolic acid, and or urea. And urea helps remove some of that scale. Because some of these products are combination products that you can get. These are all over the counter. There are no easily available prescription items anymore. And so you can buy these online if you can't find them in the store. And there's lots of good things out there. Some of these are some of the ones that I found helpful for my patients. And then you can put these under occlusion. So you can put it on and then cover it up and put it with a thin, I usually recommend a thin cotton sock so it can basically soak some of the moisture away and it can breathe a little bit. Maybe leaving that on overnight, several nights a week, can really help kind of get some of the thickness and scale down. And then of course, the deeper cracks or fissures, if it's painful to walk because of a crack or fissure, I recommend coating it with super glue. It's not going to seal the fissure in terms of closing it up, but it's going to coat it so that you don't have as much pain. And this can be quite helpful, especially for those ones around the heel that can form where it gets painful from cracking and opening up and those nerves are exposed. So just some helpful hints for caring for your feet overall. So treating palmoplantar psoriasis itself, prescription topical therapies, corticosteroids. We have really thick skin, and the psoriasis even thickens the skin more. So you have to use a high potency topical steroid. Hydrocortisone by itself is not going to work well. So clobetasol, halobetazol, betamethasone, these are all prescription high potency topical steroids. Whatever kind of vehicle you like, okay, is fine. Ointments are good if it's dry. Creams are easy to put in and not so sticky. Foams are available, and that's really what your choice is. The foams are easy to spread. You can put those on and then put your sock on and get right, to putting your shoes on and going out and doing your activities. Vitamin A derivatives such as tazarotene in combination with topical steroids can also be helpful for thick plaques of psoriasis. Topical vitamin D products, especially in combination with topical steroids, things like calcipotriene, can also be helpful, but there's an absorption issue here. And this doesn't work as well as it can, maybe on the scalp or some thinner skin areas. And then there still are topical tar and antholin products. There's even some over-the-counter products that you can get that have tar and LCD in them. And these can be very effective. They're some of our original therapies for psoriasis back to the times of the Egyptians. And some of these are over-the-counter, and you can combine them with other modalities. And that's kind of topical things that can be available. And there's phototherapy. And phototherapy can be a great way to tackle both pustular as well as plaque psoriasis of the feet. Narrowband UVB is probably the most common one that's used. This can be done in office. It also can be done at home. And often you can get insurance to cover your home phototherapy device, because coming into the office 2-3 times a week is certainly cumbersome. And I encourage patients where light therapy is going to be something that they're going to do ongoing to get their own device so they can manage it on their own and do their treatments. And this can be used in combination with other therapies. It can be used with oral therapies, biologics, topicals, etc. There's no contraindication there. Systemic treatment for palmoplantar psoriasis, all drugs that work for plaque psoriasis will have some effect on palmoplantar psoriasis, but it may take longer to see effect, and it may often take higher doses. But there are some drugs that are particularly helpful for palmoplantar psoriasis, including one of my favorites was just acitretin. Acitretin really does work both for pustular and plaque palmoplantar psoriasis. The side effects are really dose dependent, and even low doses, like 25 milligrams every other day, can be helpful for patients and can really help kind of keep them in remission. And this can also be combined with other psoriasis medications. It's not an immunosuppressant, so it does not suppress your immune system. Can do other things, can cause some hair loss, can cause some cheilitis, some dry lips, dry nose. It's kind of similar to Accutane in the way it works as being a vitamin A derivative. But this can be a helpful thing to maintain pustular psoriasis as well as plaque psoriasis on the hands and the feet. Should not be used in women of childbearing potential. That's the other key factor. Apremilast, you see ads for apremilast on TV all the time. And this has shown some effect in palmoplantar disease. And I do think it works a little better in palmoplantar disease than it does overall. Its efficacy is not, outstanding, but it does have a role, and it's certainly worth a try. Side effects here are mainly GI side effects, gastrointestinal things, nausea, vomiting, diarrhea are the big issues. And it's also not a significant immunosuppressant at all, so that's kind of nice as well. And it can be used in combination with other therapies. And this is looking at apremilast for the treatment of moderate severe palmoplantar psoriasis. And you can see there is definitely more improvement with apremilast versus placebo. And this is looking at the Palmoplantar PASI 75, so 75% improvement in the Palmoplantar PASI score. And this is just a numerical change that was seen. So this is something to consider as a treatment. Stelara, Ustekinumab is the generic name, kind of an older drug for psoriasis, but we certainly have a lot of experience with using in palmoplantar psoriasis. And there are some, especially as effective in TNF inhibitor induced palmoplantar psoriasis, which we'll talk about a little bit more in a moment. So this is the TNF inhibitors. TNF alpha inhibitors are effective. And I'll show you a case of mine from when TNFs were kind of first approved back in the early to mid 2000s, where this was effective in controlling a patient with palmoplantar psoriasis. Adalimumab did do a placebo-controlled trial. We actually did that in our clinic. We were one of the sites for that. And they found that it did work modestly. 31% of patients were clear or almost clear versus 4% of placebo. And this is the typical doses for Humira every other week dosing. So there was some efficacy here, but that's 31%. So that means, 70% or so of patients are not getting adequate control with Humira, adalimumab. Infliximab, etanercept, there's also case reports of those helping. Remicade is just a much stronger drug. Infliximab, it's IV infusion. It works much faster. And so someone who really needs a rescue, that's something that can be done. But it does have to be given in an infusion center or a clinic that offers infusions. The effectiveness is lower than seen with chronic plaque psoriasis. So the efficacy that you see in regular plaques is not going to be as high with palmoplantar psoriasis. And combination with methotrexate, acitretin can improve effectiveness. And biologic therapy can dramatically improve PPP. This is a patient with several year history of thick plaques on palms and soles, had tried multiple topical therapies, methotrexate, acitretin, and biologic therapy with adalimumab was successful. This is him before, and that's him after. So kind of hard to believe it's the same patient. But in this case, it really turned it off. Now, this doesn't always work. Adalimumab by itself does not always work, but in this case, it really did help this patient. One of the things that's important to mention is this guy was a smoker, and smoking is a big factor in both palmoplantar psoriasis and palmoplantar pustulosis. So patients that are current smokers should be encouraged to discontinue. It doesn't always help by stopping, but certainly it's worthwhile to give that a try. Now, what about some of the more modern biologics? So this is looking at Taltz, and this is looking at 100% clearance of palmoplantar psoriasis, and just a little bit over half of patients on Taltz alone were able to achieve that. So a little better efficacy than what we saw with the TNF agents. And then Ustekinumab, they actually did a study just looking at palmoplantar psoriasis. And in fact, some of these patients didn't have a lot of psoriasis elsewhere. So these are truly patients suffering from palmoplantar psoriasis. And about a third of them on the 300 milligram dose, which is the standard dose, about a quarter on the 150 milligram dose. And you can see very few placebo patients improved. Now, these numbers are about half what they are for psoriasis, okay? So almost clear numbers of psoriasis, about twice as high for general plaque psoriasis. But still some efficacy here. I've had some good results with Ustekinumab and Ixekizumab in palmoplantar disease. So these patients, again, primarily palmoplantar disease. And these are some results from this study. Baseline week 4, week 16. And again, look at that foot. I mean, the thick, yellow, scaling plaques that melt away over 16 weeks. So quite a good result here for this patient. So palmoplantar psoriasis, TNF inhibitor induced. So TNF drugs like Humira and Enbrel and Remicade sometimes can cause palmoplantar psoriasis, and sometimes it's pustular psoriasis. And it's actually not all that uncommon. It's more common in folks who do not have a diagnosis of psoriasis previously. So these are folks with rheumatoid arthritis, folks with inflammatory bowel disease that are on TNF agents that then go and develop this. Sometimes it's scalp is involved as well, but very commonly it's palms and soles. And again, usually it's for rheumatologic or gastroenterologic indications. And we see this with all the TNF drugs. And I probably see one case of this a month. It's fairly common, one patient with it a month. And it's often palmoplantar and pustular. Treatments, topical corticosteroids can be helpful. Adding on some oral treatments can be helpful. Sometimes the patients are doing so well with the TNF agent, controlling the other disease, let's say it's inflammatory bowel disease, that the doc really doesn't want to stop the TNF agent. And so we will work with them to see if we can control the TNF-induced psoriasis. But it's important for you to know about this because it's something that you may see even in yourself. This can happen in patients with regular psoriasis and psoriatic arthritis as well, but it's more prominent in patients with other disease conditions. So you can switch to methotrexate, cyclosporin, or Primolas, kind of control with that. Add phototherapy. I've done all those things. You can switch to Ustekinumab, which for inflammatory bowel disease is now approved. So that's a nice way to go, and that's been successful, as well as the IL-23 inhibitors. I have found some nice success with switching to those of late. Sometimes they can control the psoriatic arthritis well if they still have arthritis. Sometimes it's not as well controlled as it was with the TNFs. And IL-17s can also be done, but obviously with IBD patients, we need to be careful with that. And the IL-17s just don't work in rheumatoid arthritis, so not going to be an option for someone with RA and this interesting form of palmoplantar psoriasis induced by TNF inhibitors. And this is a patient that was switched from TNF inhibitor to Ustekinumab, which was one of our early on interventions because that's what we had. Now we have a lot of other options. And you can see the improvement there. So what about treatment specific for palmoplantar pustulosis, which is what the title of this presentation was, right? Well, the problem is there's just not a lot. There's not a lot in terms of data, and there's not a lot in terms of that shows great efficacy. But let's review what's out there. Certainly, many of the treatments I talked about before, such as topical treatments, can be used. This is actually one of my patients that had palmoplantar pustulosis as well as some ACH, some Acropustulosis of Hallopeau as well. So kind of a mix here. They also had psoriatic arthritis. And over the years, she was on many, many different therapies to control her disease, including cyclosporin, which was about the only thing that really gave her good control. So much more difficult condition to treat. And you often have to do more than one therapy. So if your doc is just giving you one type of treatment, that's probably not going to be enough to control this disease. So certainly systemic agents like methotrexate, acitretin, cyclosporin, and now the JAK kinase inhibitors. We have tofacitinib available for rheumatoid arthritis. We have Rinvoq, upadacitinib. We have abrocitinib available for atopic dermatitis, but Rinvoq upadacitinib is also available for psoriatic arthritis, as well as an indication for psoriatic arthritis. So these JAK kinase inhibitors can do quite a nice job treating this condition. And there's been some case reports out. I've had some experience myself with using this in pustular disease and have seen some improvement. And I think one reason why it can lead to some improvement with pustular disease is because it has so many different targets. By inhibiting the JAK kinase inhibitors, you're turning off inflammation across the board, and that also leads to some potential side effects here. So I mean, you do see you have to have blood work done while you're on these. There's more risk for infections, for cardiovascular events, etc. So there's a trade-off here. But if you're suffering with hands like these, I think you have to have a balance of efficacy and safety in terms of your treatments. And research is progressing on new ways to treat pustular disease. We do know IL-36. There's also CXCL8. There are other targets that are being addressed to go after pustular disease. Some of these targets have been proven efficacious in generalized pustular psoriasis, and we'll show some of the data for palmoplantar pustulosis. So the guidelines for treating pustular psoriasis are really based on limited evidence. This is the AAD NPF guidelines from 2020, so recent. Systemic non-biologics, there's some evidence for cyclosporin and for acitretin, both of which I've mentioned before. All of these biologics have shown some ability to treat this disease, and mostly in case reports and case series. So infliximab, adalimumab, etanercept, the TNF agents, secukinumab, brodalumab, ixekizumab, the IL-17A agents and IL-17 receptor antagonists, and ustekinumab, the IL-12-23 agents. So those are the biologics that have some evidence. So there are no approved treatments in the United States for palmoplantar pustulosis or for generalized pustular psoriasis. But Japan, where this condition is more common, they have done some approvals based on very small trials, small numbers of patients, but that did show some efficacy. This includes secukinumab, ixekizumab, brodalumab, the IL-17s, guselkumab and risankizumab, the IL-23s, and the TNF agents. All are approved for GPP and some for GPP and PPP in Japan. And so, we really have a dearth of great treatments for this condition. And that's frustrating. It's frustrating to physicians, it's frustrating to patients. And again, it's often going to take more than one treatment. and even maybe being on several treatments overlapping over time to get control. And then maybe another treatment to maintain control. So to get it under control, get the pustulation down, and then something that's going to keep patients clear over time. So there's really kind of oftentimes kind of two treatment periods for patients with pustular disease. There's getting the pustulation down, and then there's preventing it from flaring up again. So this is a study done with Cosentyx where they looked at Palmoplantar Pustular Psoriasis, okay? And this was considered a negative study. The high dose did show a little bit of improvement over placebo. The 150 milligram dose, not so much. But I do think there's a signal for some improvement here. And this was for pustular palmoplantar psoriasis in particular. And they enrolled quite a few patients in this study. This is the largest study in pustular palmoplantar psoriasis ever performed. And again, after you follow these patients out a little bit longer, it seems like the active patients on drug do a little better over time. So I don't think it's really a negative study. It certainly did not meet statistical significance. But there's probably a signal for some efficacy here with Cosentyx, an IL-17A inhibitor. Frontiers, the IL-23 inhibitors, I really do think play a role, especially in that maintenance of effect over time. So whether it's Guselkumab, Tildrakizumab, or Risankizumab, I think all three of them can play a role in maintenance of the condition. Topical and systemic JAK kinase inhibitors, again, not approved for psoriasis, but we have them approved now for atopic dermatitis, psoriatic arthritis. And so we do have access to getting these drugs. And they actually may be a good way to go for controlling the disease up front, but not necessarily staying on the drug long term. And that may help prevent some of the side effect issues that we have that concern us about JAK kinase inhibition. Topicals in development, they're approved for atopic dermatitis. We have a new topical for atopic dermatitis that is a JAK kinase inhibitor that likely would have some effect in psoriasis as well. It's being studied. Orals in development for psoriasis, but are approved in atopic dermatitis. And then we have the TYK2 inhibitor, which is going to be out probably within the next year or so. And that seems to have a little bit less of the side effects of the JAK kinase inhibitors and can work quite well for psoriasis. I'm excited to see how that drug may perform in pustular disease as well. And the IL-36 receptor antagonist, we're going to show you some of the results of that. Certainly is effective for generalized pustular psoriasis. But the results are less robust with Palmoplantar pustulosis. So this is imsidolimab. It's one of the anti-IL-36 receptor monoclonal antibodies. And this is the effect overall. You can see placebo and active arms are about the same. But there was a little trend towards some improvement if you looked at some subpopulations. Patients with who were smokers tended to do a little bit better, but not an overwhelming turning off of the disease, which would really be nice to see. One of the important things here that I haven't mentioned so far is that there are more women with palmoplantar pustular disease than men. And so that's and smoking, current smokers were 60 and 62% in the two arms in this trial, which is much higher than the background population of smoking in the US. And so that is a big factor in Palmoplantar pustulosis, and it's something that definitely, if you could switch to a patch or gum and get away from the cigarette or the electronic cigarette, that would be a good plan. But the story's not over here. I mean, there may be ways of making these drugs work better in patients with Palmoplantar pustulosis. And here's another study with Spizolimab, which is an anti-interleukin 36 receptor antibody as well. And at week 16, 32% of patients with Spizolimab achieved 50% improvement versus 23.8% with placebo. But it was not statistically significant in this study. But there's another study going on as well, and so we'll see. But we were hopeful that this was going to work really, really well. Unfortunately, it looks like it's not going to work really well, but we may have some effect from it. So psoriatic arthritis. There were lots of questions about PSA. And as you know, PSA and psoriasis and pustular psoriasis in particular can coexist. And sometimes I think it can be difficult to tell whether the pain is coming from the plaques or pustules on the feet or actually from the joints. Common things we see with psoriatic arthritis is swelling and pain around the Achilles tendon, which is Achilles tendinitis, which is very common with psoriatic arthritis. Sausage toes and fingers that you can see, which is called dactylitis. Plantar fasciitis, which some people don't know is associated with psoriatic arthritis. So sometimes I'll have patients come in that get repeated injections of cortisone into their feet for plantar fasciitis, and their psoriasis kind of goes up and down with those steroid injections. And they never really put it together that there was an association, but there certainly is. And stiff feet in the morning that loosen up over the day, those are kind of common things we see with psoriatic arthritis. So if you have PSA and you have pustular disease, I really do think that biologic therapy with or without an oral agent would be the way to go. And certainly topical therapies can be helpful to treat the plaques and the pustules of the disease. So what do you discuss with your dermatologist? Well, number one, when you go in for an appointment, be prepared. I mean, have a list of the questions and concerns that you have. I think that's great. When a patient comes in with a list of their concerns, it's fantastic because it helps set what we're going to discuss during that visit. So don't be afraid to do that. I think that's really good. It shows that you're putting your time and effort into the whole process as well. Important questions the dermatologist may ask, how long have you suffered with it? What treatments have you tried? Are you using any over-the-counter products? What kind of moisturizers, etc.? What symptoms you experience, pain, burning, itch, and when those are, and what activities bring those on. And then the most important thing is, how much is this messing with your life, right? How much is this keeping you from doing the things you want to do, your employment, your social activities, the sports, the other things that you enjoy doing, and how much is this really impacting you? Because I think the balance really becomes what treatments you want to undergo. It is really a balance between the impact of the disease, and if it's impacting you dramatically, we need to do something that's going to get your disease under control. Accept prescription creams and ointments as first-line treatment, so you can try those first. But if it's not working for you, you need to let your doc know. Some doctors are much more aggressive and willing to try different therapies than others. Some are afraid to use any systemic drugs for psoriasis. So you have to make sure you find the right dermatologist as well. And the NPF's resource in terms of finding dermatology is very helpful. If a doc is listed on there, they're going to take your disease seriously. Phototherapy, again, can be quite helpful in office and also with a light box at home. Oral medications, both the old and new biologics. And so ask about these and whether they're appropriate. Again, if topicals aren't controlling your disease, you need to go beyond that. You need to go to ultraviolet therapies, systemic therapies, biologics. And don't give up if several treatments don't work. In fact, expect several treatments to not get you where you want to be. That would be the expectation for palmoplantar psoriasis and palmoplantar pustulosis both. Both conditions are hard to treat, it takes time, and it's going to take often more than one therapy to really get things under control. And try to follow through. I know it's frustrating, and I know it's a pain to come in for appointments, it's a pain to get your prescriptions filled, and if a prior authorization needs to be generated, there can be calls back to the office and all. But if your goal is to get yourself better, you're going to have to invest your time and effort in this whole process as well. And with appropriate treatment, you can take this and you can turn it into that. And that is a dramatic improvement. And I've shown you some other patients with dramatic improvements in their psoriatic disease with the whole retinue of therapies that we have. When I finished residency, we really didn't have much. We had cyclosporin, methotrexate, we had phototherapy, TARS, we had some retinoids, but not a lot. And so we had to kind of rotate through those different toxicities of those medications. And so the really Herculean effort to develop new drugs for psoriasis, which began back in the late 90s, really has come to fruition. And now we have so many, over a dozen approved products for plaque psoriasis, many of which, have shown some efficacy in palmoplantar disease and palmoplantar pustulosis. So we have a lot of options available now. There's really no reason why any patient should have to live with disease like this. It doesn't make any sense. We can get this better, but you do have to give it a chance. And you do have to take a little bit of a potential risk for some side effects as well. So we're going to open it up to some questions.
Great. Well, thank you, Dr. Crowley. That was pretty amazing. So we do have some questions. The first one alludes to symptoms. Is it better to pop pustules or leave them alone? And what about picking at the dried up skin?
Yeah, so the problem with picking is that oftentimes you can create more damage than's already there, and you can create deeper fissures that just don't want to heal. So really manipulating the lesions a lot. I know sometimes it's hard not to, right? I mean, the urge to want to pick at like a scab is a pretty strong one. But I would really try to stay away from that. I would use, things like the topical therapies and the moisturizers to get some of that scale away and get the pustules down, which it will do if you use it, especially under occlusion. Steroids under occlusion can really be helpful for the pustules. As far as opening them up, I mean, if they're really ready to open up, I mean, I think it's okay to pop a couple of the big ones. I wouldn't go and pop them all, but if there are some that are really just kind of throbbing and tender, I think relieving the pressure from those can be helpful. I'd kind of just unroof that little top part, and I wouldn't be aggressive with it, but I don't see any reason that you shouldn't do that, but I wouldn't do it extensively. Pain is horrible and you just got to do something, so I get it.
And when people get pustular psoriasis on their feet, do they usually have it on both or just one foot?
Yeah, it can occur. I have some patients where just have it on one foot or one palm, and that's the only place they have it, and it's just kind of stubborn and stuck there. It's a bizarre thing, but it can be just on one hand or one foot. Now, one of the things on the feet that you can get, which can be a mimic of pustular psoriasis, is pustular tinea. So it's actually fungal infection. And this can occur especially if you have bad fungus involved nails and you're putting topical steroids on. So we have seen that. So, it sometimes can be important to treat an antifungal either orally or topically in patients with foot palmoplantar pustulosis because this can be a kind of a co-infection that can occur.
And you mentioned nails. Is there anything someone can do about pustules forming under the nail and then they actually lose the nail?
Yeah, so this is a common hallmark of psoriasis. You can get these oil droplets are actual little pustules that you can get underneath the nail, which can lead to nail destruction and lifting up of the nail and nail loss over time. Unfortunately, topical things and phototherapy really doesn't work very well for these because that pustule is so deep down in underneath the nail. So you're really going to need a systemic therapy. Again, something like oral drugs such as methotrexate, acitretin, JAK kinase inhibitors, cyclosporin even, or the biologics. IL-17 for nails, predominantly nail disease. IL-17 antagonists are my favorite.
And this individual indicates they have ACH. They've had it for 12 years. It's painful, and they just started intralesional steroid shots 3 months ago. Do you have any success with ACH that is not a systemic medication?
Yeah, I mean, it's a systemic disease. So, if you don't address it as a systemic disease, and basically, if you're doing a bunch of intralesional steroid injections, you're getting systemic levels of steroid in your system. So don't think that you're not getting systemic drug. You are. So you're going to have to accept it as a systemic disease, and it's going to need systemic therapy to really control it adequately. Some of those things may help give you some relief, which is great. Topicals may help give you some relief, but you're getting bony destruction with ACH, and there's really no way to prevent that except from using a systemic agent.
And switching to treatments, you mentioned nail disease. Do fungicides aid in prevention?
So the deal with antifungals and nails is that if you have psoriasis, if you have pustular psoriasis, just regular psoriasis, and it's causing destruction of the nail, you're going to get a secondary infection with fungus because the fungus just is everywhere and it can get in underneath there. And so sometimes by treating with antifungals, you can actually get some improvement, especially if the disease is long-standing. So, you can do cultures. There's ways of clipping nails and sending them off to have them evaluated to see if there's fungus there. And if there is, treating that can often be helpful. Topical treatments are okay, but oral treatment works the best for treating nail disease. That's fungal.
And should you remove lesions on your feet either by freezing or cutting?
Well, neither. The key thing is to really get into a routine with good moisturizers that have acid or urea in them, because they're going to get rid of that dead skin. Okay, that's what's going to work long term. Cutting is going to leave you with bigger fissures, potential for secondary infection. Freezing is just going to lead to blistering and potential problems as well. It's also painful. So neither. I would recommend getting into a good routine, good moisturizer under occlusion at nighttime with or without topical steroids would be helpful.
And what treatment can you recommend if someone has pustular psoriasis and they're also breastfeeding?
Yeah, so I mean, topical therapies can still be used, and certainly this would be a great place to use phototherapy. I would highly recommend that because that's going to have no impact whatsoever. Obviously, biologics, some of those will get into breast milk. Some of the oral medications will get into breast milk as well. There is the biologic certolizumab pegol, Cimzia, which is not transferred into breast milk. It is not really measured at all in breast milk. And so if it's needed to be on a biologic therapy, that may be one to consider.
Do you happen to know if Medicare covers phototherapy equipment?
So Medicare will cover in-office phototherapy. They will not directly cover home phototherapy units. Sometimes your secondary insurance or additional coverage that you have can. You can also buy some of the phototherapy units not for a whole lot of money. Sometimes you can get used phototherapy units on on Craigslist and those kind of things too. You have to be careful with what you're getting, but those can be approaches that you can get phototherapy for patients on Medicare. But Medicare itself, as far as I know, does not pay for home phototherapy units.
And Medicare, according to this individual, also doesn't cover a lot of the topicals and Skyrizi. They're denied financial aid.
I mean, the problem with Medicare is that the federal government considers it a kickback for any company to offer a rebate on their product. And so all of these, rebate programs that you have with regular insurance, once, you go on to Medicare, they can't be used anymore. And so it does become much more difficult to get biologic therapy, specific topical therapies, absolutely. Now, if your income is low, you can get them, but it has to be pretty darn low. That's the other issue. There are patient assistance programs. A couple things that Medicare patients can get access to, all right, and those are infused agents like Remicade. Also, Cimzia can come in a vial that can be charged to Medicare, which is a TNF agent, so that's another TNF that's available. And tildrakizumab Ilumya also is available to patients with Medicare in a buy and bill fashion. I use a lot of Ilumya in my patients with Medicare because it's billed directly through the medical benefit of Medicare, and they have no out-of-pocket cost at all as long as they have a secondary insurance. It's not the most active IL-23 agent, but it can be very effective. I have used it in pustular disease, more of it as a preventative for recurrence of pustular disease. And it can be effective. I've used it in Palmoplantar Psoriasis as well. So that's another thing that you can get too. But you have to have a doc that's willing, or a clinic that's willing to actually buy it and bill it. And not everyone's going to do that.
Great options. And for lifestyle, you mentioned stop smoking. Are there any other lifestyle changes that someone could make?
I mean, I really do think that diet plays a big role, and certainly alcohol plays a big role in flares of psoriasis. Eating a healthy diet, Mediterranean diet, lots of fruits and vegetables, nuts, olive oil, versus a fast food diet, I think can make a dramatic difference in your psoriasis. Controlling weight can also make a difference in psoriasis, and in palmoplantar psoriasis as well, because with the feet you have less pressure, and that can play a big role as well. Also, obviously, not easy things to do, but things that can make a big difference.
And what about PUVA? Is that a potential option if someone were to try that?
Sure. The problem with PUVA is that the supply of the medicine that's used to put onto the lesions has really been hard to get, to the point where we had such trouble getting it for so many years. We actually moved our PUVA unit out and got another narrowband UVB unit. But if someone still has the UVA available, and you can get compounded the topical oxorolin, it can be a very good treatment. It's better than narrowband UVB, but you do have to put the medicine on. It has to incubate for a good while, and then you're treated with light. But if that's something that's available to you in your area, absolutely can be a great treatment. And it is something in the past which I've done a lot of.
And our last question, why does the body form the pustules in the first place?
Yeah, so we actually know a fair amount about what's going on in pustular psoriasis. If you look at a pathology slide of psoriasis, one of the key elements that you see is the neutrophil. And the neutrophil is a white blood cell that's present both deeper down, but also it actually is present in the skin itself. So even a typical patient with psoriasis has micropustules. Okay, so psoriasis is filled with these micropustules. Can't see them from the outside, but they're part of the plaque of psoriasis. So with pustular psoriasis, you get overdrive of the things that attract the neutrophils into the skin. They're called chemoattractants, chemokines, and those things just get out of whack. CXCL8, there's others that drive the neutrophils into the skin. So they pull them out of the blood and they flush them into the skin. And that's what causes generalized pustular psoriasis. It's what causes Palmoplantar Pustulosis as well. And so a lot of the current theories are to try to turn those chemokines off. And IL-36 is one of the targets to stop the chemokines. IL-36 is actually broken down by the neutrophils themselves and activated. So that's one of the targets. But there are other targets that are being looked at as well, and that can really go after the specific overdrive of your immune system that's present in pustular disease.
Well, thank you, Dr. Crowley. That was excellent, and thank you for taking time to answer all of our questions.
Thank you all for your excellent questions. I got lots of them we didn't get to, but really excellent questions, and it really shows me that you're really thinking about what's going on, and that's awesome.
Thank you.
Thank you. Thanks to the NPF as well.
For additional resources about pustular psoriasis, you can visit the Pustular Psoriasis Resource Center at the URL listed on the screen. Pustular Psoriasis Resource Center offers information, resources, and stories to help you continue to learn more about this type of psoriasis and what you can do to live a better life, less impacted by symptoms such as what Dr. Crowley discussed today. In addition to information and stories from others who have overcome pustular psoriasis, you'll also have access to podcasts and another webinar about Palmoplantar psoriasis. Today's webinar from Dr. Crowley will also be placed in the Pustular Psoriasis Resource Center once available. The Patient Navigation Center is the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Patient Navigation Center to ask about connecting with others through the one-to-one program by calling 1-800-723-9166, option 1, or send a request to psoriasis.org/education. In addition to this webinar, you can continue to learn about psoriasis and psoriatic arthritis through NPF's podcast series Soundbites, which is available through Apple Podcasts, Google Play, Ghana, Spotify, iHeartRadio, Amazon Music, or a feed service of your choice. You can also access podcasts at the website listed here. If you'd like to hear more about pustular psoriasis, listen to episode number 104, What to Do About Pustular Psoriasis, from dermatologist and Vice Chair of the National Psoriasis Foundation Medical Board, Dr. Christina Callisteffen. Or you can hear dermatologist Dr. Robert Kalb with episode number 134, addressed Let's Talk, Hard to Treat Psoriasis. Thank you again to our sponsors, Amgen, Janssen Pharmaceutical Companies of Johnson & Johnson, and UCB for their support of today's webinar. Please take the survey via the link you receive after viewing today's webinar to provide feedback about the presentation and content. Tell us what you think. We value and appreciate your comments. And finally, you can catch this webinar and other presentations in our webinar archive at psoriasis.org/watch-and-listen. This concludes our presentation for today. Thank you for joining us to view Caring for Your Feet with Pustular Psoriasis.